Our next speaker is Professor Peter M. Nilsson, and he is the Professor of Clinical Cardiovascular Research at Lund University, Sweden. His main interest is in hypertension, vascular aging, insulin resistance, and type 2 diabetes. He is the panel member of the Malmo Offspring Study for transgenerational research of family risk patterns of chronic disease. He is also a board member of World Hypertension League, WHL, and he is going to talk to us now on risk factor control in type 2 diabetes, an update. Over to Professor.
Thank you very much. It's interesting to come to India, a country with a growing number of patients with diabetes. I learned that here in Tamil Nadu is the highest prevalence of type 2 diabetes in India, so it's the right place to give this presentation. I'm going to address risk factor control in type 2 diabetes, speaking on new guidelines and some discrepancies between guidelines, but also the common message. Of course, we see new guidelines from Europe, from United States, from Canada, international guidelines. I will pick a few of them. I will focus very much on blood pressure control, as that is what I have been dealing very much with in the last few years. I will also touch upon some new data from randomized controlled trials using DPP-4 inhibitors, because that contributes to our understanding of glycemic control. What is the role of new guidelines? I think they should be educational, but also respectful, because you clinicians, you know your patients and the personal needs and background factors much better than anybody else. So I have been a council member of the European Society of Hypertension. A leading person is Professor Giuseppe Mancia from Milan, and he usually tells that guidelines should be educational and not prescriptive. So this is the way we use guidelines. I start with blood pressure. Everybody here knows very well that there is a more or less linear relationship between elevation of systolic blood pressure and risk of cardiovascular complications in patients with diabetes. However, based on randomized control intervention trials, it has been much harder to show benefits associated with an ambitious blood pressure lowering. One of the most recent trials, the Accord trial, failed to show positive evidence of a benefit for going very low, less than 120 millimeter mercury systolic blood pressure, for avoidance of complications. Yes, there was a positive finding for the secondary endpoint, prevention of stroke, but not for the primary endpoint, all cardiovascular events. So this is the dilemma to be handled by guidelines. Let me review with you some blood pressure goals for patients with type 2 diabetes based on recent guidelines over the last 2 years. In 2012 came the European Guidelines on Cardiovascular Disease Prevention in Clinical Practice. 9 learned societies worked together to write these joint guidelines, and it was stated that the treatment target for blood pressure in diabetes was less than 140/80, with a strong evidence base. So people tried to collect all the data, all the evidence, and they came out with this. Of course, we know that office blood pressure is perhaps not optimal. 24-hour ambulatory blood pressure recordings are much more informative, and many patients with diabetes have masked hypertension. For example, they have nocturnal hypertension that will never be detected by office blood pressure recordings alone. So there are some caveats, there are some problems with the data based on office recordings, but this was what was stated 2012. In the United States, the American Diabetes Association kept for a long time their old goal, less than 130/80, but last year and also this year, according to Standards of Medical Care published by the ADA, they accepted a blood pressure goal below 140 millimeter mercury systolic blood pressure over 80 for most of the patients, but keeping less than 130 still for patients, younger patients, less comorbidities, and shorter diabetes duration. But as you can see, the evidence level was lower, level C, for this goal. According to nephropathy, we know that macroalbuminuria is a factor linked to cardiovascular disease, where the blood pressure goal should be less than 130/80. However, microalbuminuria has been more debated, and there is a split opinion, but many advocate less than 140/80 for patients with microalbuminuria because lack of evidence. So this was the American view. Last year were published the European guidelines on the management of arterial hypertension by European Society of Hypertension, my organization, in collaboration with the European Society of Cardiology. I was responsible for some of the diabetes aspects here in collaboration with other colleagues. So a summary slide to show you that the blood pressure goal based on evidence was less than 140/85. So the same systolic blood pressure goal, but a little bit different diastolic. This can always be debated, whether you rely on UK-PDS data or the HOT trial or whatever, but this was nevertheless what was stated in the guidelines. You should know that there was also a warning to use the combination of two blockers of the renin-angiotensin system, because based on other studies, this has been shown to be associated with adverse effects on target and also the altitude study. Otherwise, many agents can be used in combination therapy. Last year was also published another set of guidelines from the European Society of Cardiology in collaboration with the European Association Study of Diabetes for evaluation of risk factor control in patients with diabetes, prediabetes, and cardiovascular diseases. Let me just mention that in this week's issue of the BMJ, there is a critical debate signed by John Judkin and somebody more on the prediabetes, not to over-explore this concept. So if you are interested in a critical debate on prediabetes, take a look at the BMJ. Nevertheless, this set of guidelines was published last year. It was headed by another Swedish colleague, Professor Lars Rydén from Stockholm. So even if Sweden is a small country compared to India, we try to do our part in the international guidelines work. Also in this set of guidelines, the blood pressure goal for patients with diabetes was set to below 140/85. So this is currently the European view. In these guidelines, there was also a summary slide on gaps in knowledge, as stated here, and you can see that the authors recognize that optimal blood pressure targets in patients with diabetes are unknown. So even if we have a lot of trial data, there is no randomized control trial to go below 120, below 130, below 140 in the same trial, because ACCORD was below 120 versus below 140. They missed the third arm below 130, so we are still left with a question here for the optimal blood pressure goal. And as I mentioned to you, ambulatory blood pressure recordings will show us another picture, and in the future I hope for more studies applying ambulatory blood pressure recordings. However, there are also some other guidelines. This was recently published by the International Society of Hypertension and the American Society of Hypertension, clinical practice guidelines. And if I select just blood pressure targets for patients with diabetes, you can see that some of the other guidelines reach other conclusions, less than 140/90. But in Canada, people still keep the old goals, less than 140 over 80, based on a recent publication from 2014. So this is quite interesting, that based on the same evidence, the same data, different set of guidelines reach different conclusions. Maybe the only way to sort this out is to do more intervention trials in the future to learn more and to apply ambulatory blood pressure recordings, as well as measures of arterial stiffness, very important for patients with diabetes. How to treat hypertension in diabetes? As I mentioned to you, I guess most of the antihypertensive drugs can be used, often in combination, however not combining two blockers of the renin-angiotensin system for the indication of hypertension treatment. What about lipids? We know that LDL cholesterol is extremely important to get under control in patients with type 2 diabetes. In fact, in the UK PDS study, the observational arm, not the intervention arm, the observational arm, it was shown back in 1998 that LDL cholesterol was the most important risk factor for coronary heart disease among other risk factors in patients with newly detected type 2 diabetes. So LDL cholesterol is important, less than 2.5 in most patients, less than 1.8 in patients at very high risk. But the current debate is very much on whether we should use target dosage or target goal. In Europe, we believe, or we have believed for a long period, in target goals, as I just mentioned to you, less than 2.5 or less than 1.8. But in recent guidelines from United States, also from the NICE institution in the UK, people have been thinking more about target dosages. Forget about goals, they tell, just treat with a evidence-based dosage of a statin. So according to this recent set of American guidelines published by the American Heart Association, it stated that there are 4 statin benefit groups, and number 3 includes individuals 40 to 75 years of age with diabetes and LDL cholesterol within this range, without clinical atherosclerotic cardiovascular disease. So it's a clear statement that many of these patients benefit from statin treatment. And you know there are a few studies, for example, the CARDS study, to show benefits in patients with type 2 diabetes treated by statin. Also the heart protection study had many diabetes patients, and a number of other clinical trials. But the Americans, and now also Britain, people from the UK, recommend that the intensity of statin therapy should be the goal of treatment, not to go for any other goal, but the dosage of the statin therapy. So in my country, Sweden, we try to make a compromise. We think that a goal of a statin dosage is appropriate for most patients, but in the very high-risk patient, we should still use treatment goals, because then you have to tailor the therapy in a much more individualized way. Finally, some words about glycemic control. In most of the guidelines, the HbA1c goal now is set to below 7.0% or less than 52 millimole per mole, but with individualization, of course. Elderly patients, frail patients should not have such an ambitious goal. It should be individualized. There are many drugs to be used, often in combination, and there is also this algorithm providing a bit more clinical freedom, how to choose the second line of drug therapy after metformin. Everybody loves metformin, it's top of the list, But in fact, there are meta-analyses to show less convincing data for cardiovascular prevention as compared to what was told from the UK PDS study. I still believe metformin is very useful, should be widely used, of course, but in the modern way, we often combine. And as you can see here, the second line of drugs, there is clinical freedom, taking into consideration efficacy, effects on hypoglycemia, weight, major side effects, and of course the costs. So in the end, you tailor the right combination therapy to the right patient. And in the end, there could be insulin therapy. So the early combination approach is now stated in most of the guidelines, as is also individualization of therapy. In the old days, we tried lifestyle intervention for a long time, but now the trend is to go for early drug treatment, especially with metformin early on. Just recently, we learned about some new studies, cardiovascular effects by use of gliptins. I will just briefly touch upon the studies. It was the SAVOR study comparing saxagliptin with placebo in more than 16,000 type 2 diabetes patients. It was the EXAMINE, a smaller study for secondary prevention in patients with type 2 diabetes, placebo controlled. But the overall result was neutral, both for SAVOR and for EXAMINE, like this. No significant difference between treatment arms. However, there was a trend for increased risk of hospitalization for heart failure associated with the gliptin treatment, as seen here from SAVOR. And if we combine the two new trial data sets, there is an increased signal of risk of hospitalization for congestive heart failure. The third major trial, TECOS, by use of sitagliptin versus placebo for secondary prevention, will be released by the end of this year or early next year. So then we will learn the third trial data on this specific problem. However, on the other hand, there were no serious adverse reactions, no increased risk of pancreatitis, no increased risk of pancreatic cancer. So this is exactly what the FDA demanded, and that was the primary reason why the studies were started. But as I have shown you, no added effect on cardiovascular prevention. So in summary, I think you know very well that diabetes is a cardiovascular risk condition. We should go for this multiple risk factor control, as shown in the STENO2 trial. Now we have flexible goals for control of hypertension and hypoglycemia to avoid the adverse effects. Lipid levels should be low, but I guess in many, many patients we can go for a goal dosage, not a specific lipid goal. And I told you about recent developments according to guidelines and recommended blood pressure goal for patients with diabetes. Thank you very much.
Thank you very much for taking us through this.
The other one.
Taking us through the risk factors, mostly the blood pressure, and emphasizing the ambulatory blood pressure monitoring in contradistinction to office blood pressure, and setting us the target, the new target of so-called JNC8 of 140/80 for everybody who told us the 130/85 or 140/80 and load, and also the nocturnal dippers, and also spoke about your ideas regarding the LDL, which has been again new guideline, has some doubts about the way, and we have discussed it very well. And of course, last not the least, the new drug, the saxagliptin, and the severtimid trial, where he had more serious admissions. Thank you, Peter. Please sit down, and we'll have the discussion together.